Dear colleagues, I'd like to thank the organizing committee and Professor Silvia Vajic-Sanetsky for inviting me to present this topic and to be part of this symposia. My name is Mirjana Doknić. I work at the University Clinical Center of Serbia at Clinic for Endocrinology, Diabetes and Metabolic Disease at Neuroendocrine Department, Medical Faculty of Belgrade. I'm going to talk about the effect of medical treatment on pituitary size in acromegaly, and our clinical experience is the most important significance for all of clinicians. Beside the IGF-1 and growth hormone normalization, especially important medical treatment goal in acromegaly is to control or to reduce tumor mass. But this subject is often in the shadow of the focus on biochemical control, and new studies related to this subject are lacking, comprehensive studies. Estimating of pituitary tumor size has some limitations. Standard formula using three different diameters and geometric approximations are not precise for larger, irregularly shaped tumors. Then MRI assessment depends on expert subjectivity. Reports related to changes in tumor size are incoherent due to different studies design, different doses, duration of medical treatment, then the time of implementation of medical treatment. Tumor size changes larger than 20% are considered significant for macroadenomas and 3 millimeters for microadenomas. After microadenoma surgery, the disease remission rate is significantly higher than after macroadenoma surgery. The problem arises when tumor remnant persisted and remains after transsphenoidal surgery, and then medical treatment plays the main role. Medical treatment can be used as the first line of treatment if surgery is contraindicated in cases of invasive, aggressive adenoma growth with cavernous sinuses infiltration and in patients with high preoperative risk. In addition to biochemical control, octreotide and lanreotide, first generation somatostatin analogs, also inhibit tumor cell proliferation, tumor cell growth by two known mechanisms. One is direct antiproliferative through activation of somatostatin receptors with consequent apoptosis and cell cycle inhibition. And the other is indirect by inhibition of angiogenesis and growth factors. Literature data showed that overall tumor shrinkage occurred in about 50% of patients treated with octreotide and lanreotide as primary or secondary therapy, secondary considered after surgery. And tumor volume reduction was quantified, and it was about 50% of starting tumor volume. However, tumor shrinkage not always correlates with the degree of biochemical control. There are concept tumor resistance and biochemical effect resistance, so it means the different signaling pathways in somatostatin signals in pituitary. Octreotide and lanreotide used as first-line therapy are more effective than after surgery, and the meta-analysis showed that tumor shrinkage was detected in about 48 to 80% of treated patients during follow-up of 1 to 5 years. The largest tumor shrinkage was observed in the first 6 to 12 months of treatment, as shown on this figure, and it is supported by another study by Colau et al., which showed that tumor volume reduction was minimal after 1 year of treatment with octreotide, while after 5 years was insignificant. In line with that, we have recently demonstrated the dramatic tumor reduction on lanreotide treatment as first-line treatment before surgery in this giant somatotropinoma, where we noticed that after 3 months of treatment, tumor shrinkage occurred, and continuing this trend, after 12 months of treatment, we noticed on MRI cystic intratumor degeneration and further shrinkage. Later, this patient underwent transsphenoidal surgery. Octreotide and lanreotide used as adjunctive therapy after surgery are less effective, and large meta-analysis enrolling 900 acromegalics showed that tumor volume reduction was detected in 20% of patients on octreotide used as second-line treatment, while percentage was significantly higher when they were used as first-line treatment. However, one Italian study showed opposite results. They showed that patients poorly responsive, tumor responsive to octreotide before surgery showed significant tumor volume reduction after surgery. So nature of tumor behavior is often unpredictable, and the reason for less efficacy after surgery can be explained by the scarce tissue after surgery in pituitary region, anatomical morphology changes in and different estimation by MRI observer. This figure showed that lanreotide induced significant tumor volume reduction in 63% of patients, but it is interesting to notice that 2% of patients in the same study showed tumor volume increase. What would be predictors of greater tumor volume reduction during octreotide? The percentage of IGF-1 decrease is the best predictor of tumor response on octreotide and lanreotide. Then early efficacy is predictive for long-term effect. In older patients at presentation, those with prolonged octreotide treatment at higher doses and those with the T2 hypointense MRI signal, adenoma can be better responders on octreotide and lanreotide in terms of tumor volume. Pasireotide, despite the fact that pasireotide is superior to octreotide and lanreotide regarding biochemical effect, they have a similar response, tumor response, according to these sizable trials, clinical trials, and they showed comparable tumor response on these medicaments. However, patients with inadequate biochemical control after 1 year of octreotide showed significant tumor shrinkage after switching from octreotide to pasireotide. And again, it is important to notice that some patients showed increase in tumor volume even though on pasireotide. Some patients are resistible to every medical option, and we should keep in mind that fact. Pasireotide induces a tumor cell necrosis and cystic degeneration, as shown in this figure by Rotterdam group. The same group of authors showed novel results regarding predictors of response to pasireotide on tumor size. In their cohort of 45 patients, tumor volume reduction was detected in 73% of patients, and in 6 patients was detected tumor volume increase. These patients with better tumor response had higher IGF-1 and after first generation somatostatin analogs, higher IGF-1 after 3 months of pasireotide. It is surprisingly because we expected the better response after better biochemical response, but this study showed these interesting results. Then better responders can be expected in those with lower somatostatin receptors 2 expression, higher T2 MRI signal intensity, and larger tumor and presentation. Real-life studies offered more valuable resuls, and in this, the longest real-life study lasting 14 years, this Brazilian group showed significant tumor reduction on pasireotide in more than 60% of patients, and it is proof that pasireotide is superior to octreotide and lanreotide regarding tumor response. All guidelines and algorithms recommend pasireotide as 2-line and as a 2nd-line treatment option. And there are only 2 case reports describing pasireotide as 1st-line therapy in de novo acromegaly. And this Italian and Japanese group showed that pasireotide induced a significant tumor reduction in de novo acromegaly. The cost is always a problem, and this is the reason of this small number of literature data regarding tumor volume on pasireotide in de novo acromegaly. Also, patients with AIP mutation showed significant effect regarding tumor size, tumor volume on pasireotide treatment. We know that these patients are resistant to octreotide and lanreotide, and pasireotide plays the main role in these kind of patients, AIP positive acromegaly. Dopamine agonist effect on tumor size varies, being up to 30% of patients, and better response can be expected in those with co-secreting growth hormone and prolactin secreting adenoma. Some patients previously partially responsive to octreotide showed significant tumor reduction after addition of cabergoline, as shown on this figure. Since the beginning of the use of Pegvisomant, there is a special concern regarding tumor growth on Pegvisomant. However, later studies did not corroborate and support these findings. Possible mechanisms involved in tumor growth on Pegvisomant are still elusive and multifactorial. Pegvisomant interrupts the negative feedback controlling GH secretion, and in that way it accelerates tumor growth, perhaps, if any. And rebound phenomenon is also a possible mechanism because almost all patients on Pegvisomant are previously treated with octreotide or lanreotide. Again, tumor growth might reflect the natural history of tumor independently of medical option which is used. Earlier studies before era of Pasireotide showed that Pegvisomant induced tumor growth in 3% according to these two studies, and this figure, this MRIs showed that increase of tumor volume on Pegvisomant. However, observing whole group, whole cohort, mean tumor volume did not change significantly, what is one of the proof for high safety profile of this drug. In estimating of predictors of tumor growth during Pegvisomant, this Spanish study provided interesting results. In their cohort of 75 patients resistant to octreotide, tumor volume increase was detected in 5 patients, and their MRIs are shown on this figure. Increased risk for tumor growth can be expected, such as in these 5 patients, in those with macroadenomas, absence of previous irradiation, shorter duration of octreotide before Pegvisomant, and in those with higher GH levels, younger patients with aggressive tumor, and those with AIP mutation and MEN1 mutation. Tumor growth is usually seen early in the first 6 months of treatment, if any is detected. It is important to estimate which tumor growth is clinically important. Radiological relevance and clinical relevance are not the same. This study, German study, showed interesting data and very useful for us clinicians. Out of 310 patients, tumor size increase was detected in 20 patients. After MRI assessment, meticulous MRI assessment, it was confirmed in 9 patients. After detailed analysis, only 1 patient had Pegvisomant-related tumor growth, and his MRI showed on this figure. So only 1% of patients required Pegvisomant discontinuation, and it is again safe. It is proof for safe, high level of safety of Pegvisomant. What do large databases say? Acro study performed on more than 1,200 patients with acromegaly, follow-up almost 4 years, showed that tumor increase was detected in 7% of patients after a local MRI reading. After central MRI reassessment, it is confirmed in 3% of patients. The same results showed later Acro study on more than 2,000 patients, follow-up 8 years, and the tumor increase was Pegvisomant related in only 1% of patients, and 0.5 of them required withdrawal from Pegvisomant. Combined use of Pegvisomant and octreotide or lanreotide has been shown as safe and effective medical treatment option. The large study from Rotterdam group showed that out of 141 patients, only one patient had tumor volume increase on that medical treatment option. When to do MRI follow-up? Initially, MRI should be performed every 3 to 6 months after transsphenoidal surgery. But if the size of the tumor remnant is stable, annual or biannual MRIs are recommended. Intensive MRI follow-ups is not mandatory, especially in older patients at presentation, those with smaller, less aggressive tumor, and those with the hypointense signal on MRI. Of course, worsening of clinical symptoms during treatment and exacerbation of comorbidities demand an immediate pituitary MRI. In conclusion, tumor volume increase and tumor volume decrease can occur during all medical treatments in acromegaly. So it's not just an attribute of a particular drug, Pegvisomant or octreotide or Pasireotide. Pegvisomant can be considered as a safe modality treatment, especially when it's used in a combination with octreotide or lanreotide. But if the focus is on the tumor size with the risk of compromising optic chiasm or cavernous sinus, Pasireotide is the drug of choice. And we always should apply the personalized approach to all our patients with acromegaly. Thank you for your attention.